Okay, shall we start?
Sure.
Okay. Good evening, everybody. Welcome to this edition of Isgk Kerala PG Clinics. And today we have Professor Banu Vikram Pillai as a faculty. Professor Banu Vikram Pillai is a diplomat of the American Board of Gastroenterology, Pediatric Gastroenterology and Pediatric Consultant and head of the Department of Pediatric Gastroenterology at Amartha Institute of Medical Sciences, Kochi. A warm welcome, sir, to our clinics.
Thank you.
And the case of today will be discussed by Dr. Jerry Abraham from VPS Lakeshore Hospital, Kochi. And the discussants are Dr. Parag Sims, Chennai, and Dr. Sadguna Rao, Chennai. So welcome, Dr. Jerry, Dr. Parag, and Dr. Sadguna Rao. And we have Jayanti ma'am as our moderator. She has been the pillar, and I would say the strong pillar of this program, both from the Kerala side as well as Tamil Nadu side. And ma'am has been actually awarded the Sarvapalli Best Teacher Award of the Isgk Kerala chapter. Okay, all of you have seen that in our WhatsApp group, etc. So we are extremely happy to have ma'am with us always. So warm welcome, ma'am, also. With these words, I will request Professor Banu to take over and Dr. Jerry to upload your slides. Over to you, Professor Banu.
Yeah,
We'll be in the background.
Yeah. Please go ahead and start the case.
And one more request, the house rule, except the presenter and the discussants, all the others, please keep the audio video and the mute because this is to save the bandwidth. Okay, so except the presenter, discussant, and the lead faculty, the faculty can of course keep the audio video on anytime. All others, please keep the especially the audio and the mute form. Okay, over to sir.
Go ahead, Jerry.
Sir, am I audible, sir?
Yes.
Good evening, sir. Moving on to the case. 17-year-old female who was a +2 student hailing from Alleppey. Informant was patient and mother, and history was reliable. The patient date of admission was April 2nd. Presenting complaint: loose stools 45 days, blood and mucus in stools for 45 days. History of presenting illness: patient was apparent.
We lost your audio.
Jerry, for the time being, you can switch off your video. I think Jerry has a connection issue.
Yeah.
He has to come back.
Yeah.
Jerry is logged off. He will have to come back. Yeah, it's coming. Jerry, in case you have got bandwidth issues, you can keep the video off for a while. Was it a lost? Then you can continue talking. If you have problems, you will tell. If there is a disconnection in the audio or the sound quality, we will let you know. Okay. Are you back, Jerry?
Yeah, yes, sir. Yes, sir. I'm online.
Go ahead.
Can you
please.
start again?
No, the previous slide, please. Yeah.
So patient was apparently normal 1.5 months back. That is in February 2023. She had normal bowel movements of 1 to 2 per day, which was of Bristol 3/4. She developed loose stools, which were small volumes, 3 to 4 stools per day, and gradually increased over a week to 8 to 10 bowel movements. She noticed blood and mucus in her stools, initially once or twice per day in small quantities, and later blood was present in almost all the stools. Feeling of incomplete evacuation and urgency was present. History of Ayurvedic medication intake for a week after the onset of symptoms, and she had only partial relief. And later, after a week, in view of persistent symptoms, patient consulted a doctor, and she had 2 courses of antibiotics and medications over 2 weeks to which she had some relief. And for the past 6 days, loose stools with blood and mucus increased to 10 to 15 per day with nocturnal symptoms of 4 to 5 episodes per night with occasional passing of blood clots. History of anorexia was present. History of weight loss of about 5 kg over the past 1 month. History of associated generalized tiredness and easy fatigability was present. There was no abdominal pain or bloating sensation. There was no perianal pain, discharge, or swelling. There was no history of fever, recent travel, or outside food consumption prior to the onset of symptoms. No similar symptoms among classmates or family members. There was no history of constipation. There was no pain or redness involving the eyes. No history of skin lesions, oral lesions, or genital ulcers. There was no history of joint pains or back pain. Past history, there was no history of any similar complaints in the past. No history of tuberculosis. No history of any radiation. She was fully vaccinated up to age. Personal history, no addictions, no high-risk behavior. She attained menarche at 11 years of age and periods are regular. Family history, she is an elder child of non-consanguineous marriage, no history of TB or IBD among family. Socioeconomic status, she belongs to an upper middle class according to modified Kupusamy scale. Diet history, 24-hour dietary recall. She was consuming 1,860 kilocalories and 50 grams of protein before the onset, and now consuming only 1,000 kilocalories and 25 grams of proteins. Treatment, there was not only regular medications till now. So to summarize.
Just wait. Professor Banu, do you want to have any clarifications?
No, let him present it so we can ask any questions after that.
Okay.
And only one question that I had was, you said she had 2 courses of antibiotics before the things, after the symptoms started. Do you know which antibiotic they were?
Actually, Jerry has gone offline. I think he has some connection issues. Okay, we'll just wait for 1 or 2 minutes.
Sure.
According to the story, the patient received 2 courses of antibiotics after the initial Ayurvedic treatment. That's what I understood.
Right, but I was asking whether he knows.
He didn't mention which antibiotic. Yeah.
Right.
Unless they have good internet connection, this happens. This happens.
That's the reason I decided to stay in the hospital before I finish.
Very often this happens. That's why I made both of you co-host. Sometimes my connection also drops off in between. Highly sort of undependable sometimes, even though we have got fiber optics, etc. Okay, Jerry seems to be totally. If that is the situation, I will have to. Anyway, we know the case. He'll be back. Jerry, yes, Jerry.
So, Jerry, do you know what were the 2 antibiotics that she got after the onset of symptoms?
So we had no information about the course of antibiotics.
Okay. All right.
Then summarize, please. Come to the summary slide.
1 minute, sir.
Are you at home or in the hospital? Your net seems to be weak.
Yeah, I went to the hospital, sir. I used to stay back during presentation, but.
Okay, but what you do that if there is an issue, you can switch off the video part of it. Okay. Okay, now you.
Sir, is my screen visible? Summary slide.
Yeah, yes.
So 17-year-old female with no significant comorbidities presented with chronic diarrhea with blood and mucus of 1.5 months duration, which is of large bowel, inflammatory bloody type of diarrhea with anorexia and significant weight loss, with no perianal symptoms, extraintestinal manifestations, pain abdomen, and no other symptoms of malnutrition with ECOG performance status 1.
What is ECOG, Jerry?
European Consortium for in patients with malignancies, performance status.
Yeah, Eastern Cooperative Oncology Group.
Oncology.
Okay, all right.
So shall I?
Yeah.
Examination. So the syndromic diagnosis is chronic large bowel inflammatory diarrhea. The differentials I would like to consider are a first episode of inflammatory bowel disease, ulcerative colitis more likely than Crohn's colitis, Second differentials I would like to consider is an infective colitis. And other less common possibilities can be lymphoma or a polyposis syndrome, which can present with lower GI bleedings.
Okay. Why did you put IBD as the first possibility rather than infective colitis?
One, due to the duration of the illness, sir. It was lasting for about more than a month now, and she has had history of 2 courses of antibiotics. So acute infectious diarrhea lasting for more than a month and not responding to antibiotics is less likely, though it is more common and when compared to the IBDs.
Okay. Okay.
Suppose
what
we
do you-
are given an antibiotic of not the correct antibiotic. Nowadays, drug resistance is fairly very common.
Yes, sir.
So, second thing, we didn't say it is bacterial diarrhea at all.
Right.
It can be so many other causes.
Okay, sir.
So when you have an acute, actually it's a borderline, no? This is a situation where it is just crossing the persistent diarrhea into chronic.
So 45 minutes.
This tricky situation we have to discuss acute as well as chronic. It's a borderline time.
Yes.
Mostly it's presented with acute, and if you have seen the patient just 1 week ago, you would have called it really a persistent diarrhea. Okay.
Yes.
So what is the duration for chronic diarrhea in children?
So more than 4 weeks is considered as a chronic diarrhea.
That's in adults. In children, it's 3 weeks.
Okay.
3
Children,
weeks.
yeah, children is 3 weeks, and there is some other one more definition called protracted diarrhea or persistent diarrhea. That usually start with an acute presentation, which lasts more than 2 weeks. So more than 2 weeks starting as an acute presentation, lasting more than 2 weeks. That can be termed as persistent diarrhea or protracted diarrhea. Once it causes more than 3 weeks, it's considered chronic diarrhea. So chronic diarrhea doesn't have to always start as an acute presentation. That's a difference between the persistent or the protracted versus the chronic.
Can you explain that once more?
So what start with an acute presentation, like an acute gastroenteritis or acute diarrhea, when it's persisting more than 2 weeks, that's considered either protracted diarrhea or persistent diarrhea.
Persistent diarrhea. So it has to have an acute onset.
Acute onset. But if it's any diarrhea lasting for more than 3 weeks, which need not start as an acute presentation, that is considered chronic diarrhea.
So chronic means only on the duration part.
Duration only. It does not have to start as an acute presentation. It's just, can be.
In adults, we consider chronic after 4 weeks.
4 weeks, I know. That's the reason I asked specifically that question too. Okay.
No, Jerry, please wait. But you, in your summary, just go back to summary. You have said it's inflammatory. What were the points to suggest it was inflammatory?
The only points in this patient favoring was the presence of blood and mucus in the stools. There was no history of any, as per the history, there was no history of any fever during or before the onset of symptoms. So it was more of a large bowel type of diarrhea due to the symptom and based on the volume symptoms, and inflammatory or bloody diarrhea based on the content of the stool.
What will be other differential diagnosis of a blood and mucus diarrhea?
If it has been a somewhat elder patient, I would have considered the possibility of an ischemic colitis.
Okay.
Or if there has been a history of radiation colitis presence with the bloody diarrhea.
Okay, but you consider infective colitis, no? So you must also be able to tell which all organisms were in your mind. Or which was the microbial organism responsible for this, or any other type of organism.
Bacteria which can cause infective include, which will last for more than a month, can be seen with Yersinia colitis, or Campylobacter infections can persist for over a month. And with the history of multiple antibiotics, and can be a superadded Clostridium difficile bacterial infection is also a possibility. Viral
only
infections.
2 courses, no?
2 courses of antibiotics.
And most probably they were different also.
Yes, sir.
Okay, and if you so you think this current diarrhea is actually C difficile?
No, nothing, no fever, nothing.
Okay, you mentioned.
Specific.
Why can't it be the common bacteria which produce dysentery, which we see often?
Invasive organisms like Shigella or Salmonella can cause bloody diarrhea, but lasting for 45 days is less likely with respect to the normal.
Because the duration is 45 days.
45
Okay,
days.
Okay.
Anything
That
other
is
than
one thing.
bacteria?
And parasitic infections, amoebic colitis is less likely to last, which is mostly present with an intermittent course, and lasting for this much duration is less likely.
But
And
it was not treated, no? Only antibiotics are given. So if antibiotics are given, amoebic disease may have a temporary relief, but still continue, linger on, no? This particular disease is known to linger on unless you treat it properly. What is against amoebic colitis? Is there anything? There was no abdominal pain, there was no fever,
no systemic manifestations was present.
Was she continuing with the schools and other things?
Yes, sure. She was having the +2 exams in between. That's why she had taken oral medication, was staying at home. Once the symptoms worsened, she came to again after the exams in start of April.
So didn't have any fever, no prostration, no abdominal pain, which are the classic features of a severe bacterial dysentery. Nothing was there.
No systemic symptoms was present, sir.
Okay.
Has she been abroad?
No, sir.
What is the relevance of that question? Because many parents live in Gulf nowadays. Many students also stay abroad in the initial part of their schooling, and then when they cross SSLC, they come to Kerala for further studies. And so does a stint in abroad, especially during childhood, suppose they are in Gulf.
Strong tail.
Gulf has nothing to do with strong elements. But I agree, it's a worm.
And endemic, amoebiasis is endemic to India basically. So
amoebiasis is endemic to all developing countries where hygiene is not at par. Okay, what I was mentioning is Balantidium or Bilsariasis and all those stuff which are more common but very unlikely. Okay. So you should have considered bacterial disease which is persisting or prolonged. Second one is protozoal.
Yes, sir.
Is there any worms which can produce blood and mucus diarrhea?
In children, Trichuris trichura can cause occasionally cause bloody diarrhea. And
which type of children? Healthy,
immunocompromised.
Not having any problem, or some other type of children with some other type of illness.
Immunocompromised children.
That means you mean to say which immunocompromised situation?
Combined variable immunodeficiency.
Banu sir, is that very common?
No, it is not. It's.
I think this happens in extremely malnourished kids. Extremely malnourished kids living in extremely poor hygienic situation. So two things together. They have extreme malnutrition. On top of which they are very poor conditions, so that there will be extensive Trichuris infection. But I think during our period and all we saw, but nowadays it's a historical entity, maybe. Just for completion's sake, I would just say the endoscopic appearance is described as coconut cake appearance. Coconut cake.
Okay.
It will be like the colon is smeared with whitish curly stuff, and you may think as though it is a coconut cake. Coconut cake is a remnant of the coconut after the oil is extracted. In Malayalam, it is called tenga pinnak. Okay, pinnak. So it is a coconut cake which is smeared on the mucosa. But these things are of historical interest. Maybe you can see the picture for a quiz, etc., etc.
Okay.
Ma'am, you want to add something?
SRUS was discussed.
Pardon?
SRUS.
There was no history of constipation, ma'am.
That you have to just ensure that you mentioned that. Okay.
Oh, okay.
What is the presentation of polyposis? You mentioned something about.
Polyposis syndrome can present with blood in and stools, ma'am.
But will it begin? Will it have acute diarrhea like a presentation?
No, more of insidious.
Second thing, when another problem, Jerry, here you are committed to inflammatory diarrhea in your summary. In fact, you are committed to colonic inflammatory diarrhea. Okay.
Okay.
And once we are committed to that, then going back to lymphoma or polyposis syndrome will be a little bit difficult. So you must be sufficiently diplomatic in your discussion, not to commit too much
Okay.
in the summary. Once you commit, then and making any diagnosis out of that commitment will be considered as irrelevant thinking. So that should not happen. So lymphoma and
Large bowel
can it be
lymphomas.
lymphoma? How often you get lymphoma of the intestine presenting like this?
Mostly seen in old age only, sir. And ulcerations causing hematochezia is a rare presentation.
How does polyposis syndrome present like this?
Polyposis can present with a long-standing diarrhea with large polyps causing
Which polyposis actually present with the diarrhea?
extensive
The
colon.
classic polyposis will not present, no?
Okay, no, sir.
Which are the ones which present with the diarrhea?
Juvenile
Diarrhea.
polyposis,
Pardon?
FAP, juvenile polyposis.
FAP doesn't present with diarrhea, no?
They come
FAP may
bleeding.
be totally asymptomatic, and that is why many people present for the first time in adulthood with a colon cancer.
Right.
Occasionally, they may have a bleeding PR.
Bleeding, that's all. not
Okay,
diarrhea.
that's it, which may be ignored as piles or something. Okay, that may be. But diarrhea as such is diarrhea as a manifestation of
Polyposis not
concrete
common.
Canada syndrome that you described. Concrete
Canada.
Canada syndrome, and there's one more syndrome which you described with the chronic diarrhea with polyposis, etc. And perhaps you have got a villus adenoma. Villus adenoma may produce a lot of diarrhea, especially mucus diarrhea. And sometimes there may be a little bit of bleeding, etc. But not the polyposis syndrome. And concrete Canada syndrome is something which we have been only talking in theory. I think we have never heard, seen this, and it must be extremely rare.
Yes.
Is it seen in pediatrics?
No, it is very rare. It's very rare.
No, even in adult, it is also extremely rare. Few cases reported in the world literature. That's all. So closing on, it is either IBD, ulcerative colitis,
Okay.
or rare possibility of infective with the bacteria or some parasites. We don't know.
Okay.
Can we proceed?
Yes, please do.
Coming to the examination, patient was conscious oriented. There was no dehydration. Height of 164 centimeter, weight of 60 kilogram, BMI of 22.55, mid-arm circumference of 22 centimeter, pulse rate of 128 per minute, BP of 110/70 in right upper limb in supine position. Patient was afebrile. Head to foot examination, pallor was present. There was no icterus clubbing, neck no palpable lymph nodes, skin showed no erythema rash, pedal edema was present. Examination of gastrointestinal system, oral cavity, lips, gum, teeth, buccal mucosa, tongue was normal. Examination of abdomen, scaphoid abdomen, umbilicus central, no scars, sinuses, dilated vein, no visible pulsations or peristalsis, hernial orifices were normal. Palpation, no local rise of temperature or tenderness, liver and spleen not palpable, no palpable mass, abdominal girth of 86 centimeters. Percussion, liver span 12 centimeter, no free fluid shifting dullness. Auscultation, bowel sounds heard normally. For rectal examination, altered and fresh blood staining noted. There was no perianal fissures or perianal fistula seen.
Just an interruption. What is this altered and fresh blood? What was altered when you saw?
Sir, it was like dark colored clouds.
Dark means which color?
More of maroon colors.
Okay, so but tell the dominant one, don't confuse, because altered can be anywhere from melena to maroon, no?
Maroon.
So that adds, see, my interruption now could have been avoided if you are a little more specific.
Oh, okay, sir. Understood.
Okay, fresh blood seen because okay, that's all.
No mass palpable. Respiratory system, normal vesicular breath sounds. Cardiovascular system, normal heart sound. Central nervous system, normal. So I would like to keep after the examination, I will keep the syndromic diagnosis of chronic diarrhea, large bowel, inflammatory, complicated with anorexia, weight loss, no extraintestinal manifestations, no comorbidity, with performance status ECOG 1.
Okay.
To give the etiology, now after your examination, we don't have any syndromic
Okay, sir.
Diagnosis. Yeah.
So the differential diagnosis is still the same with acute. You see possibility of acute severe ulcerative colitis with the patient having tachycardia, pallor, and stool of more than 6 episodes, stool with blood more than 6 episodes per day, and the other differentials remain the same, with Crohn's colitis being another possibility, infective colitis.
If it's a 1-year-old child coming with a 6-week history of bloody stools, what are the other possibilities you have to consider?
In young age, allergic colitis is a common differential diagnosis because
Yes.
Okay. Can present.
Anything else? Suppose it's a 1-year-old child coming with bloody stools for a month. Diarrhea, child is losing weight. Usually they are febrile also.
Again, infection. Infections. Rotaviral diarrhea.
No, rotavirus diarrhea does not cause blood in the stool.
Blood.
It does not cause blood in the stool. So it is just watery stools. Rotavirus does not. Okay. Okay. Suppose this child, so 1-year-old child had a history of constipation before. Now coming with the bloody diarrhea. What are the other possibilities you have to think of?
Fissures involving perianal fissures causing.
Fissures generally produce constipation, no?
Yeah.
Or the constipation actually triggers fissure, which indirectly increases constipation.
Blood in the stool. But this is a child who had constipation.
Okay.
Now coming with bloody stools for 3-4 weeks or 2 weeks or whatever. So what are the another strong possibility you have to think of? That somebody stand up in your mind, in your clinic with that. Somebody put intussusception. No, intussusception cause, acute onset presentation. They come with acute abdominal pain with red currant jelly stools and that kind of thing. So it is blood in the stool, agreed, but it's an acute presentation, not for several days or anything. Think of Hirschsprung's enterocolitis. So child may have Hirschsprung's disease. Hirschsprung's disease initially can come with constipation, of course, but in infancy, so a good group of percentage of patients may come with enterocolitis. They will have constipation, suddenly get infection, they get very sick. And in the past, and they can get into megacolon and things like a big problem. So that is the main reason, even in the newborn period, when the child has delayed meconium passage, the surgeons will go ahead and do the rectal biopsy and immediately do it, because infants are more likely to get Hirschsprung's enterocolitis. The mortality rate is high. So it's very, very important to keep in mind that is a younger child. Older child, would have been a long-standing history of constipation, or would be more, significant or more, the history would have been more open. So in infancy, this is something to keep in mind as a possibility. So don't forget that. It's not Hirschsprung's disease. Not everybody come with constipation. Not everybody comes in the first few weeks of life either. So only about 50% will present by about 8 years of age. So it is, it can present even later. So don't forget that possibility. And some of these patients may come with enterocolitis, Hirschsprung's enterocolitis. The child can be sick also. So keep in mind that possibility. I'm not talking about this patient. I'm just giving an example. Okay, if it's a younger kid, keep that in your mind. That's all. Okay. And as you said about allergic colitis, absolutely. It's a younger kid, 1-year-old or 6-month-old or 8-month-old. Cow's milk protein allergy causing bloody stools is a very common condition to keep in mind. Okay. And suppose this, suppose it's a boy coming with, suppose it's a boy coming with a diarrhea, like, bloody stools, weight loss, 15-year-old boy, and what other thing you have to keep in mind? In this situation, lymphoma is a possibility. A better possibility, that more likely.
Okay, sir.
Which one is that? What condition is that? Viscott-Aldrich syndrome. Viscott-Aldrich syndrome can present later or even teenage years. They can develop malignancy, especially lymphoma. They can. It's not a very common thing, but keep in mind that possibility. That if they have thrombocytopenia also, and along with that. So, and it's a boy because it's an X-linked recessive condition. So keep in mind this possibility. This is a girl, I know, but I'm just giving that, possibility to keep in mind. Okay.
So somebody has put in necrotizing enterocolitis.
No,
in the chat box.
necrotizing enterocolitis usually doesn't happen at that, this age, first of all. A 1 year old, I gave the scenario for 1 year old. The NEC happens in the newborn period, the first 6 weeks of life, usually. Later on in the first, after that to develop, either there is some other, coexisting condition like a congenital heart disease affecting the blood supply to the intestine and things like that. Otherwise, it usually happens much earlier. The first few weeks of life, necrotizing enterocolitis, yes, especially premature baby, or she has to keep it in mind, but not later. So I saw that necrotizing enterocolitis coming up. It is not a common thing for even for a 1 year old. It is not. Okay, go ahead. So how do you want to evaluate, or how do you want to proceed with this particular patient?
I think that part will be dealt with the next person.
Okay. So anything
Who
else?
is doing it?
Yeah.
Yes, sir. Am I audible, sir?
Yes.
Yeah, Parag. Okay. Yes, please.
So for investigations, I would like to divide it into two groups, sir. Investigations for managing the patient and investigations to find out the diagnosis, sir.
Okay.
Initially, for managing the patient, I would like to go with basic investigations like a complete hemogram, in which I'll expect the hemoglobin to be low because she's having frank rectal bleeding, and she's also having pallor clinically. Apart from that, she's having pedal edema as a positive sign. So I would expect her albumin to be lower than the normal. Since we are considering chronic inflammatory diarrhea as a differential, sir, I would expect her inflammatory markers also to be raised. That is CRP and ESR might be raised. Further, I would like to do a stool routine and a stool for C. diff, sir, since we were also thinking about antibiotic associated diarrhea, sir.
Stool routine means what do you want to check in the stool routine?
Sorry, whether any pus cells are there, because we are thinking of infective colitis also.
Okay.
Can it be there in
Go-
ulcerative colitis?
Yes, sir, it can be there.
Anything else you want to see in the stool routine?
RBC, sir.
Yes, there is obvious frank blood, so you expect that to happen. What else?
Any ova or cyst, sir?
So checking for ova and ova or parasites, how many specimens do you need?
Not aware, sir.
3 samples.
Correct. 3 different, 3 specimens taken from 3 different days. Why is that? Why do you want 3 specimens? Why three samples?
To have the adequate representation of life cycle OVA in this.
Sometimes the shedding can be
Okay.
intermittent. So that is why you need 3 specimens, ideally taken 3 different days to check it. Okay. And if you take only 1 specimen, what's the chance of it showing a parasite? What percentage?
30 to 40.
No, it's better than that. 60 to 70%. But if you take 3 specimens, it's almost 90% chance you may pick up a culprit if it is there. Okay, so it's important to do 3 specimens. What else advice would you tell the parents how to collect the stool?
What are the
Question.
precautions when you ask somebody to take a stool for lab test? We take it for granted
Early
very
morning.
often.
So what will you tell the parents how to collect it?
Maybe early morning samples, sir.
More than that, more important than that. I mean, early morning doesn't matter. You can collect any time because early morning the child already pooped in the diaper before the child, mother wakes up. So you may not be able to get it. So that is not sometimes possible. What else? Make sure. What about there's one more person, Dr. Sadguna? Dr. Sadguna?
Yes, sir.
So is how do you, what will you advise the mother to collect the stool? How do you collect it?
I'm thinking in terms of to collect formed stools, sir.
But the child is having diarrhea. How are you going to
Already
get the form
diarrhea, no?
stool?
I'm not sure, sir.
Make sure it is not contaminated with the urine or water, because, for example, if there is contaminated with the urine or water, that can break the vegetative forms of amoeba. You may not see it in the microscopy.
Okay.
So it's very important to collect it without contamination with the urine or water. Number one. Okay. Number two, and make sure the patient did not have had not undergone any radiological tests like a barium study that could interfere with the stool test. So you make sure it is done before you do any investigations like any barium meal or anything like that. If you are doing, I'm not telling about this patient, whenever you're doing it, make sure you collect the stool specimen before you do any of the investigations that give barium or any of those kind of things. Okay, so it's very important to make sure it is collected that way. And in a smaller child, this is a very practical question, is in a smaller child, for example, a 8-month-old or a 1-year-old child is having terrible diarrhea, how are you going to collect the stool?
Not sure.
You can take the urine, the urine bag that we use for infants to collect the urine. You can take the same urine bag, stick it up to the bottom. Okay, you stick it, adhere it to the around the anus, and the once a child's stools, you collect in the bag, in the urine bag, and you can send that, and so you can collect it. The liquid stool, you can collect it without getting absorbed in the diaper. At the same time, you get it without getting contaminated with the urine. Okay, so use the urine bag, stick it up to the bottom, and collect the stool that it comes into the urine bag. Okay.
Yes, sir.
All right, go ahead. And so what else? Yeah.
One second, sir.
Please. Yeah.
Parag said you look for stool over, no? Which
Yes.
over you look in the situation? Because
Please
it has
go
to be
ahead.
specific to the case. Because sometimes we may ask you theoretical question to assess the depth of your knowledge, but usually it will be pertaining to the case which we are discussing. So you said you look for over. So in this situation, which over you are going to look for? Okay, we discussed Tichura. Tichura is rare. Theoretically, we can say that, but in this patient is unlikely. Which protozoa you look for?
Any specific organism you are going to look for in this particular child?
We discuss in our discussion, no? Can be a protozoal illness. Which is a protozoal illness which will present with the blood and mucus diarrhea.
I think Dr. Jerry already mentioned that earlier.
Protozoal illness which will produce with the blood and mucus like a dysentery. Amoebic, Entamoeba histolytica. How will you look for it? How will you look for Entamoeba histolytica in the stool? Parag? Sadguna?
We will have 4 nuclei in the cyst, sir, with RBC inside the cyst.
Cyst.
Yes, sir.
I'm sorry, Sadguna, that's not the answer.
Trophozoites, sir.
RBCs are seen only in the actively motile trophocytes. There are two forms. In an acute diarrheal situation where there's colitis, we expect the trophocyte forms to be in the stool and we want fresh specimen. We want the fresh specimen, and ideally we should take the mucus part, not the stool. The mucus part has to be smeared with saline and examined fresh. Some people even say warm saline so that the amoeba are not killed. So actively motile trophocytes with ingested RBCs, that is erythrophagocytosis. So that has to be there. Of course, there's a giant amoeba dispar which can also produce a similar picture, but in our clinical situation, if we find a trophozoa with ingested RBCs, that's good enough. Cysts are actually seen in not in a colitis situation, but when it's a mechanism to sort of produce more progeny. So it will be in a less acute situation. Like in a chronic diarrhea case, it may find cyst. And very often cysts are not that easily found out by ordinary microscopy. You may require staining also. Okay, so amoeba is it's not that very uncommon, especially in Chennai and all. Maybe you find even some cases even now. So you must be able to answer these questions. Okay, how to look for amoeba? EH tropozoites is what we will look. In a chronic diarrhea, we may also look for EH cyst. The staining is iodine staining and iron hematoxylin stain. These are the stains which are specifically used for it. Okay, sir, please continue.
Please go ahead. So what's the next investigation you want to do? So will we show the results of the test what they asked for, Dr. Varghese?
Yeah. We,
Okay.
we usually ask them
Yeah.
to how they
So,
evaluate,
yeah,
and
please
then
show.
after that we'll show the results.
Yeah.
Hemoglobin is 6.2, sir. Total counts are elevated, 27,620, with neutrophils of 78%. Platelets are 315,000. CRP is elevated, sir, 49.2. Serum creatinine is normal. There is hyponatremia of 126. Potassium and magnesium are normal, sir. Creatinine is 1.4.
No. Just
Yeah.
go back and interpret the results. What does it show actually?
Anemia is there, sir. As well as the total counts are elevated.
Just plain interpretation shows that anemia, leukocytosis is there, profound hyperproteinemia, albuminemia, and CRP. What does it suggest? I am actually worried. I am very much worried now hearing the results. Looking at the result, I am very much worried about the patient. What am I worried about it?
Any acute infection, sir?
Acute infection, will it produce such profound hypoalbuminemia? Okay, possibly it may be if it is severe, but we were having our first diagnosis as acute severe ulcerative colitis. Okay, on examination, we found tachycardia, pulse around 120. And now we are seeing hemoglobin 6.2, TC, total count 27,000, and albumin 1.4, CRP 49. So what does it all suggest?
Whether any toxic megacolon or something is this?
No, see, she has severe, acute severe colitis. So it's like a sort of an emergency situation. Acute severe ulcerative colitis has to be managed totally differently.
Yes.
Okay, not the ordinary acute exacerbation. So that is important. So this patient has to be looked after in a much with a lot of other care, no?
Yes.
How do I explain the hypoalbuminemia?
Maybe she's losing the protein
How?
through the intestine, sir, because of the
Yeah, it is a protein losing situation because blood and mucus, a lot of protein may be lost on a day, because of the severe illness.
Yes.
Can we have some more investigations?
The stool analysis showed pus cells of 20 to 25, sir. RBCs of 10 to 15. There were no ova, cyst, or amoeba seen. Stool for GDH, toxin A and B were negative. Stool culture showed no growth.
What is the GDH?
It is used for this thing, sir, Clostridium difficile.
Okay.
X-ray abdomen was done, sir, which appears normal, sir.
Why do you want to take a plain X-ray abdomen in a patient with blood and mucus diarrhea?
To see whether any toxic megacolon is there, sir.
So how do you look for it?
There will be gross distension of the transverse colon, sir.
Okay, so where do you look at it? There must have a point where you look for it, no? The transverse colon is spread across the upper abdomen from right to left.
Yes.
So you have to have some point where you look for it. What is the cutoff?
More than 6 centimeters, sir.
Yeah, the widest portion is more than 6.
Yes.
That is one way of doing it. Okay. Suppose the patient is too sick to stand. Can you do it in the lying position? But how is it done? In the supine or in the standing?
Patient is sick.
Most of these patients are all very sick, so they won't be even able to stand. They're in ICU, so we will do it in a supine
Yes.
or a lateral decubitus if you want. Okay, next.
Chest X-ray was done, sir, which also appears normal. Blood culture and urine culture showed no growth.
Hmm.
Unprepared sigmoidoscopy was done, sir, which shows the complete loss of vascular pattern.
Why you didn't prepare?
Exactly.
Already the patient is having around 10 episodes of bloody stool, sir.
So
So
There will be a lot of blood and mucus sticking on the mucosa. You won't be able to see whether there is an underlying ulcer, etc. So won't you require cleaning?
generally in acute severe ulcerative colitis, we just need to find out the diagnosis, sir.
now what his
Is there
question is
any risk
why
of giving an
is
enema or a vigorous bowel preparation? We'll come straight to the point.
why is it unprepped scope?
Why it is unprepared?
Uh,
Yes, sir, specifically written unprepared.
Chances of perforation will be there if we do it vigorously. Enema is given, sir.
But more than perforation, I think it is a exacerbation of the illness. It will become, it is already severe. It may become much more severe. Okay, that is one thing.
Yes.
Okay, so how do you interpret the endoscopy findings?
The sigmoidoscopy shows marked friability, sir. Complete loss of normal vascular
What is the
pattern.
definition of friability?
On touching with the scope, sir, the mucosa will start to ooze, sir.
So that is a live finding, no dynamic finding. In a picture like this, can you say friability? What is more evident on a picture?
Active oozing, sir.
One is presence of blood, spontaneous bleeding. Okay, that is one thing. Okay, next.
Loss of vascular pattern and ulceration, sir.
Loss of vascular pattern, ulceration.
Yes.
Okay, loss of vascular pattern, ulcer. Why there is loss of vascular pattern?
Because of the inflammation, sir, the mucosa is continuously shedding. So
the mucosa is actually edematous. So
yes.
blood vessels become deeper. Okay, that is why. That's the first sign. Then comes friability. Then come ulcers. Then there could be mucopus, pus or blood and frying blood. Extensive ulceration. Okay, sometimes pseudopolyps or inflammatory polyps also may be seen. Okay.
What will be the Mayo score?
Here it will be Mayo score 3, ma'am.
How do you score?
We see for the ulceration, sir, whether they're deep or superficial. We see for the friability, sir, whether after touching the scope it's oozing or if there is spontaneous bleeding, sir. We also see for the loss of vascular pattern, sir.
Okay, is there any other score?
What is UCI score?
UC, EIS score.
UCIS score.
Sadguna.
UCIS score contains 3 parameters, sir. One is vascular pattern. Then when there is a partial loss of vascular pattern, it is 1, but here it is 2. And a bleeding, when there is spontaneous luminal bleed, we will give the score of 2. If there is mass, we can see only blood, no mucosa, then it is 3. So this comes under 2. And regarding ulcers, whether it is, if it is superficial ulcer, it is 2, deep ulcer 3. In this, I'm thinking there are deep ulcers, sir. So I'm giving a score of 3. The UCS score of 7 is severe, sir. So and also it has a predictability towards the non-response to steroids also, sir. This much
So
I think.
in the examination, if it is a severe UC case, you will be immediately asked Mayo score and UCIS score. So please be absolutely thorough about this, because these things are something which we have been seeing for the last 3 years. So we can't make a mistake, and any mistake done here will not be sort of accepted that easily. Okay. So common things one should be absolutely thorough.
How will you give a report in this patient? Final report.
उस वॉशरूम में है
there is complete
Nothing, doctor. I'm just asking you your final report. What will you write in the final report?
ulcerative proctosigmoiditis Mayo 3, ma'am.
Professor Banu, unfortunately, there was a got muted. Please unmute.
No problem. Okay.
I was trying to mute somebody who's
Making noise.
making noise.
Is there any other score, would you say? Please answer madam's question first.
I'll write ulcerative proctosigmoiditis with a Mayo score of 3, sir.
No, will you give a diagnosis of ulcerative colitis? This thing is just a description. No? What's your diagnosis? What will you write there? Will you put it as? Was it? I didn't figure.
Can you just
Is it-
look at the sigmoidoscopy and say it is ulcerative colitis?
That's what. The other thing was, it was unprepared, I suppose.
basically,
how far
yeah,
did they
it
go
is-
in?
This is a diffuse mucosal disease with a severe ulceration. Okay, this is what you find. So the two possibilities are again acute colitis versus acute severe ulcerative colitis. Okay, you put the score, and generally we will put peri-ulcerative colitis, acute peri-infective colitis. This is what we can say. If it is more than 4 weeks or 6 weeks, probably ulcerative colitis should be the dominant. Infective will not be considered at all. Okay.
Yes.
So, and even the way of putting the final diagnosis also is very important on endoscopic diagnosis. Okay, is it enough?
We'll take
Or will you do
biopsies.
anything?
We'll take biopsies from the rectosigmoid and rectum, sir, depending on how far we have reached. And since
You have the sigmoid which is involved, you have the rectum which is involved. Where do you want to take biopsy?
both at the sigmoid and the rectum, sir.
You want to take from both places? Any reason? Generally, when we have very severe disease, confine your biopsies to the rectum because rectum is protected on all sides. Sigmoid is in the peritoneum. So, inadvertently, if you go and take a deep biopsy, it may perforate. So, if there is no need to take biopsy from the sigmoid, specifically, you just take a rectal biopsy because exact extent of the disease we will assess later. Our current concern is actually to assess the disease and to make a diagnosis. Assess the severity and make a correct diagnosis.
Yes.
Okay, let's go to the next slide. Jerry.
Sigmoidoscopy finding showed the scope was passed up to 40 centimeters from the rectum. Entire sigmoid colon and rectum is uniformly and circumferentially involved with edema, erythema, ulcerations, loss of vascular pattern, and spontaneous bleed. So endoscopic diagnosis was ulcerative proctosigmoiditis, Mayo score of 3. To rule out infective colitis, and biopsies were taken from left colon, sigmoid, and rectum.
Okay. So biopsy. Jerry biopsy report.
The histopathology showed section shows pieces of colonic and rectal mucosa with multiple foci of necrosis covered by necrotic material and acute inflammatory exudate with admixed erythrocytes and degenerated epithelial cells. Underlying tissue shows atrophy and withering of crypts with cryptitis and crypt abscesses. Lamina propria is densely infiltrated by neutrophils with extravasated erythrocytes. There is neutrophilic infiltration of mucosal capillaries, areas of fibrinoid necrosis seen. Adjacent mucosa shows mild disorganization of the crypt architecture with goblet cell depletion, foci of reactive ATP of epithelium, cryptitis, and crypt abscesses. Lamina propria shows patchy, dense infiltration of the plasma cell admixed with neutrophils and lymphocytes. So impression.
Okay, so from this, what is your impression? What is actually? Suppose you are asked to interpret this and tell the diagnosis.
It shows ulcerative colitis, sir.
Can you say it is ulcerative colitis from this biopsy? What is the proof? I can say it is acute severe colitis.
And there are crypt distortion of the crypt architecture, sir, cryptitis and crypt abscesses.
Okay, okay, good. That's a good answer because Professor Banu.
Yes, so that's exactly what I was going to ask you. So what are the signs of chronicity in this particular case? So it's showing a lot of acute inflammation, but there are some features of chronicity also. So the crypt architectural distortion. So there is disorganization, goblet cell depletion. So those are findings of some chronicity. So it is not, so in addition, there is severe acute inflammation is there, but this is very important that suggests to a chronic inflammation. On the top of it, there is an acute inflammation. Correct.
Yes.
In the blood test, Dr. Jerry, and you didn't mention anything about the liver enzymes.
Enzymes were normal, sir. Only serum albumin was low.
Yeah, that I saw, but you did, okay.
Enzymes was normal. Sir.
Okay. All right.
Okay, what's the pathologist's opinion?
Pathology opinion was consistent with ulcerative colitis, and they had a suspicion of Clostridium difficile infection due to the presence of necrotic material acute.
Yeah, if there is a lot of inflammatory exudate seen on the surface, that is one point which they may suspect that it is infective.
Admixed erythrocytes and degenerated epithelial cells, they thought of a possibility. And after the histopathology only, we actually sent the stool, GDH and toxin, which were actually negative. But by
Okay.
that time, we had started a vancomycin also along with the.
Okay, now let us hear from the management. No? Anything else, Vanu sir?
So anything else would you want to do before you start on medications? So what did you do? Did you, what did you do the first? Did you correct the hemoglobin, or what exactly did you do first?
Yes, sir. We did.
Sir, please, Jerry, we will ask Sadguna how he will manage, and then we will ask how they did.
Okay.
Sadguna.
Okay.
So, at this point of time, I'm thinking acute, a 17-year-old female with acute severe ulcerative colitis with possible Clostridium difficile superinfection with the hemoglobin of 6.2 and albumin of 1.4, sir, with the high inflammatory markers of 49 CRP. So I'm thinking of acute severe ulcerative colitis and Clostridium difficile severe anemia. So I will divide my management into supportive management and disease specific management, sir. For supportive management, I will start with IV fluids. Because the hemoglobin is less than 10, precisely 6.2, I want to transfuse with the packed red blood cells, and in the X-ray did not show any toxic megacolon or perforation. So
Are we dealing with acute severe ulcerative colitis, or are we dealing with moderate? What will be your true Lubbock's criteria in this patient?
according to true Lubbock's criteria, it is coming under acute severe ulcerative colitis, ma'am.
So
More
what will
than
be-
6.
what is the guideline? What are the guidelines for
Guideline,
management of acute severe?
I need to manage
ulcerative
according to
colitis?
Oxford criteria, ma'am.
That's all theory,
Support-
doctor. Just tell me what should we do. We just want to know how to manage this patient.
IV fluids, PRC transfusion, and steroids I want to start, ma'am.
Sadguna, will you keep anyone else in the loop? You will manage yourself. You have your
And
your ICU.
I'll also give a surgical consult at the initial presentation itself, sir.
Okay.
Would you
Fine.
like to assess the proximal extent of the disease, or should we
No,
just
ma'am,
start
no.
off with the management?
I'll
Or should
start
not
off with the management
Is
initially.
there
you should
any
tell
way
us.
to assess the proximal extent in the acute phase?
In the X-ray, I can see that if there is a
The X-ray only if there is a lot of air, we can see the
lot of
mucosa.
air, and if there
It was
is stool,
almost
I can
opaque.
assess.
There was no
yes,
megacolon. There
there was
practically
nothing.
very little air in the colon. So, is there any method by which you can assess the extent of the disease without scopy?
A contrast enhanced CT I could do.
Yeah, it is
sir,
not
but
usually done, but if there is
it's
any
not
pressing
required.
need to do that, you can do that. That's a non-invasive method of assessing the extent.
Assessing
Okay.
the extent.
And nowadays people are using the intestinal ultrasound also.
Yes, intestinal ultrasound.
So
Very
it's very non-invasive and less expensive and no radiation. So intestinal ultrasound will be useful also. Okay.
So
Okay, Sadguna. So you will keep the surgeon in the loop and tell us how you manage. You said general management. Okay. You said you will give packed cells.
IV fluids, packed cells, and I'll try to start enteral nutrition as early as possible, and anticoagulation, because there is active bleed, active luminal bleed. I won't start low molecular heparin now, sir. I will
Why
start
enteral nutrition?
early enteral nutrition because the
why not
patient
just oral feeds, no?
oral feeds only, ma'am.
Yeah,
Oral feeds, enteral nutrition, oral feeds only. I want to continue, and compressive stockings. I want to put this patient, and disease specific treatment. I want to give intravenous hydrocortisone 100
You
milligrams.
don't see your notes. You speak out onto the video. Okay?
I'm writing.
Because you've
I
written
thought I
everything.
missed. No, ma'am. I am just listening. So hydrocortisone, I want to give 100 milligrams intravenously, 6th hourly. I want to give. And regarding follow-up, daily pulse rate, temperature, and saturation, abdominal gut, and daily.
In a severe
bowel.
patient, you don't have to. You should not wait for 24 hours. I think you should do much more frequently. No, 24 hour. If you wait for a 24 hour, that means today morning you see and you command it
Daily
tomorrow.
4 times we need
Many
to,
things would have happened.
daily 4 times we need to
Because she's a
do
sick
the
patient,
vitals.
so she required much more constant and close care. Okay. So in fact, I would say minimum 4 times a day monitoring
4
for
times.
the vitals and again abdomen for any distension or anything.
Yes, sir.
Okay.
And stool chart I want to maintain in that uh,
Okay.
frequency of the
So
stool
the patient
consistency.
actually slightly improve, and on third day practically no stools. And the bystander was very happy, and they were very impressed about the doctor. And Sadguna, are you very happy?
No, sir. I would be
Why?
more worried about the onset of toxic megacolon
Yes,
in this patient.
that's it. So if the bowel movement stops suddenly, you must be very careful. It could be that the patient has toxic megacolon. Okay, you are giving steroids for how long?
So in my mind, I'm keeping maximum of 7 days. I will give steroids, sir. But I want to assess the response on after day 3 of the steroids in the form of stool chart and CRP and fecal call protectant also will be helpful, sir. And clinical improvement, that is pulse rate, temperature, albumin. These things I want to.
Okay, suppose she has improved. Is there any difference in pediatrics, Professor Banu?
No, there's similar approach, but the thing is practically the stool calprotectin, if you send it, takes about 4 days to come back. So you may send it on
Yeah,
the
it's not
third day.
locally available. Yeah, it's not locally
Yeah,
done.
so it becomes, I mean, theoretically, yes, you can, but it is not practically not that, workable. So, you do the same thing, but make sure the surgeons are following, frequently too. So it is not something that you just consult once. Make sure you discuss with them and talk to them frequently also.
Day
Okay.
3 minimum, day 5. Okay, and if the patient improves, then
If the patient improves, I want to convert it to oral steroids, sir, and I will gradually taper. And once the oral steroid is coming less than 20 milligrams of prednisone, I want to add immunosuppressant like azathioprine in this.
what is the rule of starting azathioprine? There is a guiding rule, no?
Sir,
There must be a guiding principle to start azathioprine. What is that?
steroid free remission. I want
Induction,
to,
yeah, induction curing steroids.
and maintenance with
Yeah, or if there are,
immunosuppressants.
depending upon the number of recurrence and that, yeah, if it is mild to moderate, if it is severe, induction requiring steroids. Obviously, we treat with the steroids only in severe cases. Okay, suppose the patient has not responded, Professor Bano.
Yeah.
If the patient has not responded, that's a scenario which we want them to be thorough.
So what would you do? Is it Dr. Sadguru going to say or Parag going to say that? If it's the patient is not responding to IV steroids.
If he's not responding on IV steroids, sir, I would like to consider that is more than 8 bloody stools or 3 to 8 bloody stools with CRP more than 45.
Okay,
Then
that part is a third day reassessment. Surgeon is in the loop. Patient has not improved.
Then
Continues to
I
be
will
severely
explain
sick.
regarding a rescue therapy versus colectomy, sir.
Okay, and not only explain, you have to do it. So tell us how you do it.
So then if they are willing for colectomy, and then the options are subtotal colectomy with ileal and anal pouch anastomosis.
You will do the anal pouch immediately?
No, sir. No, sir. Not
Why
at
you
that is
don't
the
do
plan.
it?
First
Why
step.
you
It
don't
is
do it? Now you
so
said
there
no.
will
Why
be a
you
lot
don't do
of
it?
inflammatory activities, sir. So the ileal pouch anal anastomosis, technically it is not feasible, and chances of
So what
pouch
is usually
failure
done
will
in
be
acute severe ulcerative colitis? What
in
surgery?
acute severe colitis, subtotal colectomy, and
And
stoma formation they will do, sir.
ileostomy.
From where?
Ileostomy.
Ileostomy.
You
Because
said
the
what?
earlier problem,
Ileostomy.
except the rectum is cut off. So you have to have the ileum brought out. So it's a subtotal colectomy with
Colectomy with
ileostomy.
diversion.
Really clear about it. Okay. Second, the patient's family refused, saying that no, this is a young girl, we don't know any stoma, her future will be affected. Okay. So
So I will go for rescue therapy with infliximab 5 milligram per kg body weight, sir. On 0, I'll give a dose, and then wait for 7th day till 7th day. So if she's not responding by 7th to 10th day, then I will ask them to go for colectomy, sir.
or will you
Will you give another dose?
another dose? Will you just give it on a weekly basis and try to see?
Yes, sir. 0, like rapid dosing, like 0 and first week we can give, sir.
Okay.
After first week itself, we can give another infliximab dose.
And if there is a partial response, when you will give the next one?
After second week, we can give, sir. 0, 1, 2 also we can
The
give.
first dose patient has improved. So when will be the second dose?
First dose, if the patient has improved, I will give on the second week, sir.
0, 2 weeks. And then
Yes, sir.
is that the end of it?
No, sir. After 6 weeks, I will give. If the remission has maintained after 3 doses, I will take it as a clinical remission of this acute severe episode, which has responded to the infliximab. And then I think I'll continue the infliximab is one option, sir. Infliximab plus azathioprine, continuing both infliximab azathioprine at least for 1 to 2 years is one option, sir. Otherwise, according to Miracle study which was done in India, they also say that after initial induction, azathioprine and 5-aminosyl salicylic acid itself may have like a colectomy sparing disease course in about 56%. So I'll explain both the things for the
practical, doctor. Just tell, no, you have to just drop an algorithm. Just then next.
These two options I will give,
any role for tofacitinib?
There is a role for tofacitinib and also cyclosporine. So if I'm starting with tofacitinib 10 milligram TDS, I will start on first 3 days. If she's responding further, then I will come down to 10 milligrams.
Tofacitinib versus steroid. You don't have both options, no?
Tofacitinib only, ma'am. 10 milligram TDS for 3 days. If she's responding, then BD for 8 weeks. I will continue. Then
so
I will come down.
There's no role for steroid, right? So now you have to just tell us the balance between tofacitinib versus IV steroid and the follow-up of algorithm in that direction. So today tofacitinib is making a major impact, especially in acute severe ulcerative colitis, no?
Yes, ma'am.
Any precautions you need for giving tofacitinib?
Right.
I do not know at this age, doctor, whether we can give.
Varicella zoster reactive. Sorry, no, not that. Deep venous thrombosis and pulmonary thromboembolism are the risk factors in the elderly patients. But at this age, I'm not sure of.
Yeah, so I think doctor can tell us, is tofacitinib contraindicated?
What are the things that you have to do before you give tofacitinib or biological agents? What are the things you have to do before you start it?
For biological agents, I need to screen for latent tuberculosis infection and hepatitis B virus and also latent anti-HBC IgM and HIV and a CT chest and IGRA for latent tuberculosis infections, and also varicella zoster virus screening. But in this setting, I might not do all, sir. Apart from that, I was also thinking of regarding vaccination. I won't think now, sir.
No, so what about anti-HBs antibody titer?
Yes, sir. Anti-HBs antibody titers also. But
okay.
At this point of time, how much?
No, you have to check it, because if it is, not immune, hepatitis B vaccine, you can still give it. The immunogenicity will be less, but still you can give it. But it's important to check it. Okay. And ideally, you can also send the varicella zoster antibodies. You can measure it. But it is, that will take time to come back and everything. So that's a sick child. You may have to start it early. It's something which you may have to do. But yeah, so it's what else? I mean, when will you start on mesalamine for this patient? Will you give mesalamine or not?
Immediately,
Will
want
you
to
give
mesalamine,
mesalamine or when will you give it?
I will give after 6 weeks, sir.
Okay. When the child is improving, you can start it, because when
Improved
they are
and
very
everything
sick,
is stable, then I
yeah,
will.
when they are very sick, it is probably
There is
sometimes it could
chance of
aggravate the diarrhea.
paradoxical
Yeah.
worsening of the diarrhea can be caused.
Okay. And what dose would you give in children for mesalamine?
3.6 to 4.8.
That's for an adult.
Adult.
But for children, what dose would you typically start with?
I'm not sure, sir.
So you usually give about 50 milligram per kilo per day, but you round it up to the nearest tablet strength or sachet strength and adjust and give it. So you don't want to break a tablet, because you are not supposed to break a mesalamine tablet. Why?
I don't
You
know.
cannot make a mesalamine tablet, you cannot break.
Jerry.
It's designed to get released based on the pH. So breaking the tablet won't serve the purpose for the drug delivery.
So where is that mechanism situated? In which part of the tablet it is there?
The coating of the tablet.
Yeah.
Right.
MMF technology, no?
So so you started, and anything else you want to, once you started it, suppose you gave infliximab, the child is improving, and you are tapering the steroids, because the child was already on steroids to start with, you're tapering the steroids. And when will you start on azathioprine? Will you start or no?
I will start on azathioprine after 6 weeks, sir. Or when the steroid dose has come down to less than 20 milligrams.
No, I don't think we need to do that, because you can start even early, but acute, the first week or so, it is not probably going to work, because it is going to rapidly go through. But after that, even after the first week or so, or 10 days, when the child is improving, you can start it at that time itself. You can start it. You don't have to wait for 20 milligrams a day dose. You don't need to do that. I don't think you need to do that. So because it's going to take about 10 to 12 weeks to give the benefit anyway. So you can't, wait for too long. Once you start at 20 milligram, the patient will be off the steroids. Subsequent, probably 6 weeks will be off of it. So you are not enough time for the azathioprine to be on board.
Sadhguna, there is a two situation. One is a patient where induction was successful with the steroids.
Yeah.
And IV steroids, then we turn to switch over to oral steroids, and then we start azathioprine. Okay. The second situation is a situation where IV steroid did not work, and then we induced with
Then we can
infliximab. In such a patient, will you start azathioprine? And what is the current thing? Should we give immunomodulators or no immunomodulators?
We should give immunomodulators.
Why?
Because to reduce the immunogenicity
Jerry?
of
Right.
the infliximab.
Helps to reduce the immunogenicity with infliximab,
I think he has a
combining with the
audio issue.
Yes.
Parag.
We should give the immunomodulator, sir. After assessing after the first week.
Okay. So if the child is improving and you are ready to discharge the patient, what all advice will that tell the parents? So you gave infliximab also, and the steroids is already was on steroids, gradually being tapered, and infliximab is on board, and you are going to add the azathioprine to decrease the immunogenicity of the infliximab, and the child is getting ready to get discharged. Child is getting better. So no frank blood in the stool, hemoglobin is stable, albumin is pretty good. So if you are improving, when you're discharging, what all advice will you tell the parents?
Regarding symptoms, new onset fever or increase in the relapse of the symptoms, sir, and follow up after 2 weeks regarding blood count, complete blood count because of the azathioprine.
azathioprine, you have to take the baseline CBC
baseline.
plus 2 weeks after starting it or 2 weeks after any dose change, you are supposed to check it. Suppose you start with the 50 milligram, you're going to make it 75 milligram, and then you are supposed to check it again 2 weeks later, see, the blood count and the liver function test. So you have to, it's a must. You have to check it. Okay. And what else can you do ahead of time to give a better dose of the azathioprine?
TPMT assay, look for the wild.
Correct. So you can measure the TPMT, which is thiopurine methyl transferase. See, if the patient has got a normal wild type TPMT, you can even start with the higher dose of the azathioprine to even start. You don't have to start with the 25 or something smaller dose. You can give the correct dose itself to start with if the results are available and do it. Okay. Suppose you give measure the TPMT and the TPMT is normal wild type and you give the azathioprine. If the patient is coming back to you a week later or 2 weeks later with a severe abdominal pain and vomiting, what will you worry? And the TPMT is normal.
Pancreatitis as a side effect complication, as I induced pancreatitis.
Correct. Okay. So pancreatitis is idiosyncratic. It is not dose dependent, and you cannot, the TPMT assay does not give an idea about the development of pancreatitis. Okay. So it's important, if you have to watch in mind, and you have to tell the parents, if the child develop any of this, to immediately bring her to your attention. Okay. Anything else will you tell the parents? The child is going home on infliximab and tapering steroids and azathioprine. What other advice will you tell the parents?
Diet, NSAIDs.
Okay.
Increased red meat and NSAIDs might increase the chance of flares.
Red meat issue and all. I mean, yes, you can limit it, but the milk products and the red meat and wheat sometimes can be considered a pro-inflammatory, so you can decrease. But that is more of a problem for Crohn's disease. That's more of a problem with the Crohn's disease than UC. Okay. So, but what other advice will you tell them? If it's a Crohn's patient, yes, you have to definitely advise avoid milk products, avoid wheat products, avoid red meat, and avoid popcorn and processed food. Those food items you have to avoid. Okay. But what other advice should you, anything else other than this? You have to make sure you tell the parents they put sunscreen for the child. Every time when they get out of the house, they have to wear sunscreen. Why?
As I induced hypersensitivity.
More than hypersensitivity.
Melanoma formation.
Not melanoma.
Non-melanotic skin cancer.
Non-melanotic skin cancer. So both infliximab and so the azathioprine both are well known to increase the risk, and tofacitinib too. All are known to increase the risk of non-melanotic skin cancer. Okay, so you have to make sure the child put sunscreen every time when they get outside the house. It's very important. Okay, and anything else? How often do you recheck the blood test on these patients? The child is stable, child is improving, child is stable. How often do you follow the blood test?
First after 2 weeks, sir, the counts are normal. Then once again after 2 weeks. From the second month, once in a month to check the blood counts and the liver function tests.
For how long once a month?
Till 6 months, it should be sufficient for one monthly investigation.
Okay, after that?
After that, once in 3 months, we can check the blood investigations in the form CBC and LFS.
So if the child is stable, you don't, after a few weeks, you don't have to check every, this thing. But once they are stable, a stable patient, you need to make sure we follow the liver function test and CBC every 3 months. Every 3 months is very, very important. Okay, don't give a prescription and tell them to come back after 6 months. Don't do that. So you make sure you repeat it. And if they are far away, they have to do a blood test locally and inform you in a good lab, inform you the results of it. Okay, so otherwise you will miss a lot of potential side effects from the medicine. So it's very, very important you monitor that, and ultimately you are responsible for it. Once you give prescription, you are responsible for it. So make sure you follow that, and it's your responsibility. Okay, and she's a teenager. What else advice would you give him?
Not sure, sir.
Vitamin D supplement.
Teenager abroad.
Vitamin D supplementation will give, sir.
Vitamin D supplements you can give, but ideally you are supposed to measure the vitamin D and then correct it and
Correct
maintain
it.
it. So that is the correct way. But even otherwise, you are not going to lose anything by giving some vitamin D supplementation. Agreed. Okay, anything else? What about HPV vaccine, human papilloma virus vaccine? It's a teenage girl, very important, not only girls, but boys also. It's important, teenagers and young adults, make sure you give the human papilloma virus vaccine. Okay, so because it's very, very important to prevent cervical cancer and pineal cancer. So these are things that we can do to decrease the risk. You may not be 100%, but you can definitely decrease the risk of it.
When surgery in this patient?
Initial non-response to steroids, or even if the rescue therapy, if it is failing, we can offer the surgery.
Suppose the patient is not able to afford infliximab, is there anything which he can use? In pediatrics, can we use other drugs like cyclosporin?
Yeah, we can use cyclosporin, but the problem is you have to monitor the levels and everything
Renal
becomes an
parameters,
issue.
magnesium, cholesterol.
Tofacitinib, is it approved?
I don't think it is approved in children yet, but I don't think it's approved yet because I have not used it actually, honestly, personally yet.
There again, I think it is moderate severity, not an extremely severe severity. I think it's not one. Moderate severity, okay. To induce remission, it can be used. I think there was a question about azathioprine and steroid. That's I think when the induction has been done with the steroids, and as we taper the steroids, we have to start azathioprine because it will take around 4 weeks at least to take the action, to have the action. But when you have put the patient on infliximab after steroid failure, many people don't say you have to taper off. It's a steroid failure, the acute phase. So you have changed over to infliximab. And once the patient improves and the patient is able to take oral tablet, azathioprine need to be started because it reduces the immunogenicity. Suppose the patient after the initial improvement comes back after 6 months with the relapse, patient on infliximab. What all things you look for?
So after initial response, now the patient came with relapse, sir. So for any relapse, first I need to think of.
We don't know relapse. He didn't say relapse. He said the patient is coming back with the bleed diarrhea.
Bleeding.
He didn't say relapse. He didn't say relapse. He didn't use the word relapse. The patient is coming back. They responded to the infliximab. The patient is now coming back to bloody stools.
So any patient on remission, if she's coming with new onset of bloody diarrhea, first we need to again rule out the soap-related infections like CMV and Clostridium deficit. Then if they are negative, then to think of relapse.
So think of all the possible causes of an acute diarrheal disease, exclude it, CME infection, exclude it, and then if everything is excluded, what does it mean?
Then we can call it as a relapse of ulcerative colitis.
While on immunomodulators.
While on immunomodulators.
So what are the possibilities? How do you assess and manage?
So then a therapeutic drug monitoring, we could do reactive therapeutic drug monitoring in this patient by doing infliximab levels and infliximab anti-infliximab antibody levels.
So what are the scenarios? Suppose infliximab level is high and there are no antibodies.
Then it is there are no antibodies and infliximab.
What are the scenarios? Tell us the 4 scenarios which can happen when you look for the infliximab antibodies and when you look for the trough levels. There are two possibilities.
Yes,
No?
infliximab
normal, infliximab low, antibody
infliximab
present, antibody absent. So you get 4
absent.
combinations. So
If
in this particular
infliximab
case, infliximab level was normal and patient was not responding.
infliximab level was normal and antibodies
This
were
actually
not
happens
there,
in acute
then
situation, not actually after
in the after
improvement.
once.
Then acute
So then
severe
it,
ulcerative colitis, you get infliximab and the patient is not responding. Trough levels are good.
it can be
Because
primary
sometimes the dose
non-response.
which we give, sometimes the dose which we may not be the ideal for the patient. Patient may be having a bigger body weight and therefore our calculation may not be adequate. So that's why we look at the trough level. Trough level was adequate, no antibodies, patient not responding. What is that called?
Then I'll think of primary non-response to this
Yeah, it's a
agent. Sir.
mechanistic failure, primary
Mechanistic
non-response. There are different mechanisms of inflammation in ulcerative colitis. We are looking
I
at
will
one
use the
pathway
other
when we give
pathway.
infliximab. There could be other pathways. So that may be the dominant one in this particular patient. So this is called primary non-response, which is mechanistic failure. So what you should do? What you should do?
So I should use a drug which is acting through the other pathway, like interleukin.
Yeah, you have to change the class of the drug.
Class of the
totally class of the drug. Okay. If you are giving an anti-TNF, you may have to think of totally anti-interleukin like that. You have to completely change it. Suppose the antibody levels are present and infliximab levels are low.
Then I'm thinking because of the
What does it
new
mean?
development, it is secondary non-response.
Okay. And what is the situation called? Infliximab levels low, antibody levels high.
And then this is because of the new antibody formation. Sir.
Antibody
So
against
I think I need antibody against the infliximab. So I will like to add the immunomodulators in this patient to.
Okay. The options are increase the frequency, so that increase the drug, or
Increase
add an
frequency.
immunomodulator, or again you have an option to change
the
the drug.
pathway.
Okay. Okay, suppose it's a young boy and the patient is not responding. Are you worried about the surgery? If the patient responded initially and then when the relatives found out that there's another option called surgery. So they actually want to have surgery done. Any problems?
Sir, the two types of one is a long
Any
term.
problem for doing the total proctocolectomy in a male?
In a male, there can be a sexual dysfunction in the patient.
Yeah, nervous erythema on either side of the rectum will be cut and they will have erectile dysfunction. Very likely. Okay, we have covered therefore the acute management and then subsequent management, antibody levels, almost everything. Okay. Anything else, Professor Bani?
No, I'm good. They are good. They are good. Yeah. And suppose they develop pancreatitis with azathioprine, what would you do?
And I would stop the azathioprine. I would not restart the azathioprine.
Correct. You
again.
should not. You should not.
Not.
And in that situation, what can you give for that particular patient to decrease the immunogenicity of the infliximab?
What are the other immunomodulators available?
Methotrexate.
Okay. But
Can
remember
you use
this.
6-mercaptopurine? That is another drug which is available.
Yes,
No,
no, 6-mercaptopurine. I don't
know.
know.
You cannot because the same mechanism of action.
Yeah, you cannot.
It
That's
is
right. So,
Okay.
but methotrexate, but this is a girl. What advice should you tell them?
Stop the drug before.
Methotrexate, if you're starting, one is if they married regarding the reproductive issues, when we need to stop at least 8 weeks before they are planning for conception, and monitoring of the liver parameters.
Yeah. So it's
Cumulative
very important. They should not get pregnant while the patient is on methotrexate. Okay. It's a
And for
well-known
some time
therapy.
also, no? It's not immediate.
Actually,
I
3
think they
months
should wait for the
before
cut-off
planning
period.
for it, you have to
Yeah.
stop 3 months before it. You have to stop it. 3 months before you're planning for planning for a family. Make sure you stop it at least 3 months ahead of time. Okay. What dose would you
One more
give for?
scenario is that patient may respond initially and then come back with the relapse and CME is positive. So how will you confirm the potential possible underlying possible CME infection? What are the options available for you to confirm it?
Yes, sir. Sigmoidoscopy in biopsy, I will look for histopathology, sir. Histopathology, cytomegalovirus inclusions, and second thing,
Inclusion bodies.
immunohistochemistry,
Okay, good.
inclusion bodies, and second
Then,
thing, immunohistochemistry, and third
okay.
thing, CMV, RT-PCR, quantitative RT-PCR. If they are more than 20 copies per ml, more than 20 copies, then I think there is active CMV infection.
20 copies, I am not that very sure. I thought it is higher
Where
value.
the 20 copies are talking about the blood or the tissue?
Tissue, sir.
I'm not sure either the actual
I think the value is still higher. I think the principle is that whether it is present in the blood or not, it is what is present in the tissue which is more important.
Tissue.
Okay.
Tissue.
Ideally, you have to do a tissue PCR and assess that there is a significant tissue level. That's the best thing. But unfortunately, that may not be available most of the hospital. So you go by the inclusion body, severity of the disease, and blood level. Okay. So these are the three. But just by blood alone, one should not jump to the conclusion.
The colonization.
There must be concomitant colonic involvement, and CME should be shown in the colon by inclusion bodies. Plus immunohistochemistry plus RT-PCR if possible. So these are the different methods. But just by inclusion bodies alone, perhaps it may not be correct to start on antivirals. One should have at least IHC or RT-PCR. But RT-PCR in the tissue is not done in most of the places here. That's what I understand.
Yeah.
I think that part in the correct blood level and the tissue level, there's a particular value. I don't remember it offhand, but I think one should be clear about that value. Okay. And what's the drug of choice?
Ganciclovir.
Any side effect? Major side effects?
I don't know.
Cytopenias.
Pumpkin. What?
Yes, sir. Ganciclovir induces cytopenias.
Okay, cytopenia. Anything else?
Hepatic dysfunction.
Infertility. Okay, read up. This is a rarely used drug, so most of you may not be thorough. Plus, at least for theoretical sake, read up use management of CME colitis in a background ulcerative colitis. Until you should be able to say how you manage. Okay, at least theoretical points. Any other important things, Professor Banu?
The other thing is that sometimes when they are young and they get married, and then most of the time they don't disclose that they had a problem before marriage, and the disclosures occurs soon after marriage. In such patients, we've had patients where you may have to resort to subtotal colectomy, have a temporary colostomy, and then allow the patient to have complete the family life, and then go for reanastomosis. Okay, very important, subtotal, because again, the mesorectal fascia and all are involved, and then we usually don't tend to touch there. Therefore, you cannot do a direct colectomy with an ileostomy similar to in a male. So there is a role for colostomy also in such patients. Subtotal, then colostomy, and then complete the family life, and then go for this. Okay. I think most of it you've covered. Both of you have covered beautifully.
I think we have covered almost every aspect, no?
They did well.
Diagnostic aspect, therapeutic aspect, acute maintenance, 5 ASA.
They did beautifully well.
Okay. So, Gandhi ma'am, you want to add some?
And the other bit, nowadays there's that complete remission. No, I think get into that deep remission. What is deep remission? Maybe just one time colitis, and after that there may be no second episode at all. So that read the various things that you look for: endoscopic remission, the deep histological remission. What are the things that you expect, and how do you follow these patients? Okay, because this is the first attack. Maybe after this she does not get an attack at all. It's not uncommon.
Yeah, acute severe. How often you get acute severe acute colitis like presentation for ulcerative colitis? Sadguna.
20%.
20 to 25% can develop.
Less than that, 10 to 15 only. Okay. How often you get ulcerative colitis without rectal involvement?
Without rectal involvement, around 5 to 8%.
A maximum 10%. What are the situations where there can be lack of rectal involvement? One is
when
de
they are
novo
on
presentation. Second one is
Pediatric,
when they are on treatment
treatment with
pediatric.
with rectal suppositories.
okay rectal therapy, steroids,
Rectal therapy.
etc. So the rectum may be much more improving, and the proximal portion may be more affected. In pediatrics,
yeah.
how often?
So it's
You know,
uncommon.
it's very uncommon to have involvement without the rectum. It's almost always
Okay.
rectum is involved. And
Yeah.
second, one big difference between the adults and pediatrics in the ulcerative colitis is even if it starts with the proctosigmoiditis, very often it extends proximally with the through the years to become more extensive disease. Unlike in adults, most of the time, if it's a proctosigmoiditis, they tend to remain that way, I think. But in pediatrics, they tend to extend, become more extensive disease with the time. So that is a more aggressive disease in children. So they tend to become more, more extensive with the time. Even if it's
in pediatrics, we get more Crohn's rather than UC, sir.
that is correct. That is
Ah.
correct, ma'am. That is correct. That is
Yeah.
correct. But even with the UC, but when they get it, is a proctosigmoid to start with. Many times it becomes more extensive with the years to pass. It becomes more extensive disease, extensive colitis.
That is adolescent and above. But in pediatrics, what cases that Dr. Malti and all keep saying
Yeah.
is we keep on talking of Crohn's rather than UC.
Crohn's is much more common. I have UC patient, but probably I would say almost 80% is Crohn's patients.
Is it Crohn's colitis or Crohn's?
It's everywhere. It's a Crohn's involving upper GI
Crohn's,
tract,
perianal.
yes, colon, perianal. It's a mixture of everything. It's
So I think when
Crohn's
you're
colitis.
discussing, when you're discussing this age group, there's one multi-center study
Yes,
from PGI and Dr. Malti and a big group.
Right.
Just read that paper. There's a consensus on the frequency of the Crohn's versus UC in the pediatric age group and the clinical presentation. They may ask all those other questions, very early, then some early,
Yeah.
UC, all those things.
Yes,
Just
very
see that you have those definitions right. And you have to know about the genetic form.
variant of pediatric.
Monogenic.
What is actually monogenic IBD?
So
Jerry, especially Crohn's disease, no? Ulcerative colitis, it is not discussed. For Crohn's,
That's what. We hardly see UC in children. It's more of a Crohn's. So,
monogenic IBD, I think it may be a short note for you. Okay, another thing, role of these markers, fecal marker, calprotectin in the diagnosis as well as the management of IBD. Is there any additional use of calprotectin in pediatric use, of, Jerry, compared to adults?
Not sure.
Because in adults, we can go for any advanced investigation like CT scan when we suspect Crohn's. But in pediatrics, you should not immediately jump and do CT scan. One of the methods will be to do calprotectin, and then if there's a high value, then that is almost sure that there could be a disease, then you go on to, rather than blindly asking for CT of every patient. Because in pediatric exposure to CT and radiation, one must be careful. Okay, so that is one thing. Second one is during the acute phase to assess the prognosis. Third, during the remission phase also, periodic estimation of calprotectin will tell you whether the patient is likely to have a relapse in the next year.
biochemical remission.
When up to 6 months, it can predict according to the value. So again, prepare another short note for fecal calprotectin and keep it ready.
and
Monogenic
ultrasound.
IBD must be
Ultrasound was
thorough.
beautifully discussed. It's a very simple, non-invasive test. It's making a
Intestinal
breakthrough.
ultrasound.
Intestinal ultrasound is it's really making a breakthrough. So I think as doctor had mentioned, please go through that.
Yes,
They're simple, non-invasive, especially to the extent of the disease. Very well mentioned.
yes. And
So I think
always
we have
when you
discussed everything,
always
no?
when you suspect IBD, always do an upper endoscopy also. Because it may look like UC, always do the upper endoscopy also. It helps you to differentiate between the types 2. So it's very important.
Especially in pediatric age group.
Yes,
They always combine lower with an upper GI.
yes, we always do. We always do.
What do you expect is around an upper GI? Is it by biopsy you look for some focal enhanced inflammation?
Focally enhancing gastritis, and also sometimes you see esophageal involvement, and even grossly itself sometimes you erosive gastritis and all those things too, but not only histologically but grossly too. And so it's important to differentiate.
Is
And
there
that
any
helps to
particular doubts in the chat box? Is there anything relevant in the chat box. I don't think that had been answered.
There are more answers to the questions.
Okay. Okay, so I think it has been a good discussion of an adolescent case, because most of our students are tuned to managing a pediatric case. So that has been, so we are extremely thankful, Professor Banu Vikram Pillai, for joining us.
Just 1 second. Just 1 second. So in case you get this is 45 days, it crosses that. But
Yeah,
today we had a presentation of 3 weeks, 3 weeks bloody diarrhea. Okay, so it is neither becoming acute, neither it is becoming it looks more like a persistent.
it is for 1.5 months, ma'am.
45 days, sorry.
It is this patient has 1.5 months, but in
That's what.
pediatrics,
No,
it is
but
3
if you
weeks.
have a patient, we had, like we discussed, a 17-year-old, or I think around that age, who has 3 weeks diarrhea, bloody diarrhea. So then all your infections, only thing, there's no fever, there's nothing else there. So just be careful about that. And then see whether it's fitting in with this. These are the patients, when you do a biopsy, you may find there's no crypt distortion. Okay. And in those situations, it will behave like acute colitis, severe colitis. These are the patients you have to repeat a colonoscopy after 3 months to look for crypt distortion.
Exactly.
So be very careful about this group. That 45 days, even singles. Luckily, this patient had that distortion of the glands. But if it was not there, you have to repeat. Maybe it was Campylobacter. It was one of those other things that we rarely see, or senior, or whatever it is, or non-specific. And therefore, such patients you have to repeat after 3 months. Ensure that once, if supposing at the end of 3 months, the biopsy is normal, then this is definitely not an ulcerative colitis, because once you label as ulcerative colitis, lifelong diagnosis. So be very careful about this group.
I totally agree, ma'am. I totally agree.
Yeah.
I hope that message is very clear now. In
Very
acute
clear.
severe ulcerative colitis, if you are seeing a patient in the first 2 or 3 weeks,
3 weeks.
it is extremely difficult to differentiate between acute colitis versus an ulcerative
Infective or some
colitis.
other cause.
So a
Absolutely.
follow-up evaluation at some point of time will be
Very
required.
important.
I had a couple of cases where actually I stopped the medication, because otherwise they'll have to take it lifelong.
Exactly.
If there is a relapse, and if they will be warned, they should be warned. So you can stop it, and then if the moment you have a problem, you come back, we'll repeat the scopy, take biopsy. And once they have a relapse, okay, it is almost sure that it is, unless it is almost sure that it will be ulcerative colitis. Okay, they have to be warned when you stop it.
So what are the findings in chronic? Some of this we've already discussed. You'll have more of lymphocytic. There'll be widening of the
Histological
lamina
findings
propria.
in a chronicity.
So apart from the disorganization of crypt architecture, we will have basal cell plasmacytosis, which is again a feature of chronicity.
There'll be thickening of muscularis mucosa. There'll be widening of lamina propria. The space between the glands will be widened.
Parallel.
Cell
That is
depletion.
normal, doctor. What is parallel is normal. Here there'll be to separate
Goblet
out.
cell depletion.
And goblet cell depletion is again acute.
Side branching.
And here you'll have glandular, you'll have glandular pattern of the crypt. They'll have this branching glands. That's a feature of chronicity, with more of lymphocytic infiltration, in which you have neutrophils. So acute or chronic. So just read that bit. What are the classical features? Okay. They've done a good job. So I think it's good revision.
Okay, so it was a good discussion, and it was a good, I think you presented well, and discussions also did well. So on behalf of ISC Kerala chapter, our heartfelt thanks to Professor Banu Vikram Pillai for joining us.
Thank you.
And we look forward to a further cooperation. Okay, and thank Jerry, Sadguna, and Parag for joining us. And good night, all of you.
Good night. Good night.
Thank you. Good night.
Thank you, sir.
Good night.
I'm closing the session.